Good afternoon, everyone. Let's start the satellite symposium. This is ACURATE neo2, precision today, assess tomorrow. I'm Joan Kim from Jeonnan National University Hospital, and the chairperson with me is Cheong Ryu. And first, I introduce the panelists who will lead the discussion. 원장 Kim and Sang-Long Lee. Today's lecture will be maybe the 15 minutes lecture and the final 15 minutes discussion. First, I will introduce the two speakers, and Cheong Ryu is to introduce the last speaker and take care of the discussion after the lecture. The first speaker is Won Kim. Kirchhoff Heart Center, Germany. The lecture title is Introduction of the ACURATE neo2 valve system. I wish you a good lecture. Please.
Yeah, thank you very much for the kind introduction. It's a pleasure to be a part of this symposium, even though I cannot be there right away. And I would like to give you some introduction to the ACURATE neo valve system that is being used in Europe since 2012. Actually, we have started with the CE mark trial with the very first generation, and now it has come to be available, the neo2 valve system, as of 2020. And I would like to show you a little bit of the development and give you an idea how the ACURATE neo works, and maybe also how to achieve best results. These are my disclosures. And as you can see, this is the evolution of the ACURATE aortic valve platform. Very early we began, and the CE mark trial began back in 2010 with the transapical system. So this was the very first device that we used, with actually at that time very good results already. And then in 2014 we received CE mark for the ACURATE neo platform, which is slightly different. As you can see, it's more supraannular, and it seems to be a little bit less bulky than the ACURATE system. And the third generation, which is in clinical use right now already in Europe, and it's in a process of IDE trial in the US, and now soon will become available in Korea, is the ACURATE neo2. The difference between the ACURATE neo 1 and 2 is mainly a sealing skirt to reduce PVL, and also the presence of a radiopaque marker that facilitates positioning. So here's some descriptions of the valve geometry. So there's the stabilization arches. You will later see how they work. They help to align the valve. There's the upper crown that helps to anchor the valve. The upper crown dimension is the waist plus 5 millimeter. The stand body height is around 90 millimeter. The landing zone is here, which also has the highest radial force. And here's the lower crown that measures the waist diameter plus 3 millimeter. The total height is around 5 centimeter. And the valve is available in 3 sizes. I haven't shown this. It's available in 23 millimeter. So in terms of the waist, 23, 25, and 27. It's also called S, M, and L. And it covers an annular range officially between 21 and 27 millimeters. So here's an illustration of how the deployment works. And other than the common self-expanding devices that are on the market, the deployment is from the top down. You see that first the upper crown opens, and then the stabilization arches. The stabilization arches help to align the valve in the annulus, and then in the second step, the lower crown is being released for full deployment, and you see how the anchoring works. And this can be done without rapid pacing. Sometimes fast pacing can be used to have more stability, but usually rapid pacing is not necessary. So this is a short introduction to the, so you have a basic idea. I would like to present to you the strengths and limitations. And I think it's good to know, if you use a valve, to know not only about the strength, but also the limitation, so you have an optimal use of the valve. Without being able, for time restriction, to go too much into detail, the ACURATE Neo has a lot of beneficial features, as you can see. It's relatively easy to use, so you can see that the implantation is quite straightforward and intuitive. Due to the stabilization arches, it is useful and suitable for horizontal aorta. There's a very low risk of coronary obstruction, and probably you have one of the best coronary access once it's implanted. Tortuous anatomies can be addressed, the fast implant. We have low gradients due to the supraannular design of the leaflets, and the ACURATE Neo, I think this is quite well known, has one of the lowest pacemaker rates among available devices. However, the limitation, and I'm talking right now about the neo1 platform, is a relatively low radial force, which can be associated, as you can see here, with incomplete expansion, PVL, and we have seen in many trials that for some reasons PVL can be increased using the ACURATE Neo. There are some reasons behind it, but on the other hand, I think too much uncontrolled radial force is not always beneficial. So here are some examples. Very low coronary uptake. You can see there's no impairment of the coronary artery. And here's a very nice illustration of how the coronary protection works. You can see what happens when you implant the sapien. You might appreciate, I don't know whether you can see clearly on the monitor what happens with the calcium. This is usually being pressed just in front of the coronary ostia, and please appreciate what happens with the calcium when you implant the ACURATE Neo. The upper crown, as you can see here, really covers the native leaflets and enables a better clearance to the coronary arteries. I've been talking about horizontal aorta, and you can see that there's a quite nice alignment. This is because the delivery system is quite flexible and the main stent frame is rather short. This has been also shown in a registry, as you can see here, with higher device success compared to the Evolute platform. You can address really tortuous anatomies here, very acute angulation. This is because the delivery system is quite soft and enables quite nice tracking. Here you can see again the distribution of the radial force, which is highest here, and this explains why, even though we implant the device in a normal fashion, so we do not have to aim at a very high position, you can see that the radial force really decreases in the lower crown here. Talking about the limitation and caveat, this is a nice summary of the first generation. So we have seen that very severe calcification, especially eccentric calcification, is a limitation. We have a limitation in terms of size coverage, so the larger sizes have not been addressed. This is in progress now with the XL, which will be available in around 2 years. And we have learned quite early that appropriate sizing is important. The ACURATE Neo is a little bit less forgiving than other valve platforms in terms of sizing, and we have learned that a little bit of oversizing is probably better, especially in borderline annular sizing ranges. And also correct positioning is of paramount importance to achieve good procedural outcomes. And here you see the main problem of the PVL. There's a lot of variety in terms of outcomes. It's because on the one hand we had observational registries without core lab and with core lab, and I think there's also a distinction in terms of experience using the device. We have found also early that, as I've shown you, that calcification, eccentric calcification and oversizing is important to achieve good outcomes. I will skip that. And here you can see also the learning curve that we made through with the ACURATE Neo. And you can see the very first 250 and the last 250 over the first 1,000 implantations that we did. And what we learned is that we had to choose a larger degree of oversizing. Cover index in the first quartile was around 4%, in the last quartile 6%. We chose patients with less calcification. Calcium score dropped to 1900. We had less eccentric calcification in these patients. Implantation depth varied a little bit. And you can see that only with these adjustments we achieved better device success, and especially less PVL, which was 7% in the first quartile and around 1% in the last quartile. And the improvement in terms of PVL was not at the cost of higher pacemaker rate, as you can see here. So I think what we can say is, despite the limitation of even the first generation ACURATE Neo, if you really employ a careful sizing and a good selection, it is possible, or it was possible, to achieve excellent outcomes, as you can see here. Of course, you have to outselect some specific patients which are very eccentric and very severely calcified anatomies, and of course the large anatomies. So if you see the change from Neo to Neo2, I already explained to you that what actually only was changed was the radial peg positioning marker for placement accuracy and the inner and outer skirt for less PVL. And Andreas is also on the panel, and he initiated the early Neo2 registry. Now I would like to show you some data with the Neo2, which really impressively demonstrates the improvement in terms of PVL. So these are the very first implantations which were done in Europe, 550 cases, and I think it's very good that all the images were core lab adjudicated at CORE, and you can see that here are the baseline characteristics. See the distribution of valve sizes. Complications were very low. Annular rupture 0, coronary obstruction 0, very low rate of acute kidney injury. And here's the primary outcome: PVL rate, core lab adjudicated, a moderate PVL dropped to 2.7%. You may recall in scope 1 and 2, PVL rate was around 10%. Mean gradient remained low with 8. Pacemaker rate was extremely low with 6%, and stroke rate 2%, mortality at 30 days 1%, so excellent outcomes. Here's another registry that we did together with Dortmund, so two high volume centers, a total of 2,800 patients. We compared our Neo experience with the Neo2. You can see Neo2 were 800 patients, Neo around 2,000. And on this one slide you can see that also the burden of PVL dropped. The rate of moderate PVL dropped from 4% to 2.5%, and also we had less less moderate and less mild PVL. You can see that technical success and device success was improved, and there were all the other outcomes were quite similar. Pacemaker rate was a little bit higher here with percent using the neo2. And I think this is a very nice illustration. We also looked at the predictors of relevant PVR, and for the neo platform, without the skirt, we found, as earlier, eccentric classification increases the risk of PVL, less oversizing, STJ analyst, the STJ seems to play some role, and the calcium amount. The overall calcium amount for the neo was predictive of PVL. In comparison to this, the neo2 also was sensitive to eccentric classification, sizing, STJ analyst index, but not overall classification. So this means that if you only have severe classification without eccentricity, the neo2 seems to be much better than the neo. And we were able to quantify it. Here you see the amount of classification that can be tolerated in terms of PVR risk, which is much better for the neo than for the neo2. This has also been shown in other registries. I will skip that, and these are my final slides. We also performed a comparison with the SAPIEN 3. You can see this is a vast number after propensity matching, 470 patients in each group. And here you can see the results after matching. Of course, we didn't treat the extremely calcified patients with the neo, but we had severely calcified patients in both groups, and you can see that PVL rates before and after matching were similar. Of course, there were less mild PVL rates with the ultra, but what has been shown before already, the gradient was lower when using the neo2 versus the ultra 9 versus 13 millimeters of mercury, both before and after matching, which is due to the supraannular design. Here you see other outcomes. I think I will skip that, and I hope I was able to show you that the suitability of the neo versus the neo2, only due to the tiny difference of the skirt, really increases the suitability of patients that can be treated, and this should be taken into account also for valve selection. And I would like to conclude the neo platform. I think due to the shortness of time, I couldn't go too much into details, but I hope I was able to give you a glimpse of the several benefits of the ACURATE neo platform, which is a relatively easy implantation, very low risk of coronary obstruction, and at the same time good coronary access. It is possible to perform commercial alignment, and I think Andreas Rück will give you a presentation afterwards. You have seen that it is suitable for horizontal and very tortuous aortic anatomies. It has favorable hemodynamics, and it has one of the lowest pacemaker rates among available devices without having to implant it very high. So the ACURATE neo2, and you can see it in the data that I've shown you, demonstrates markedly reduced PVL. Of course, it's not best in class, but I think it is very, very acceptable, very good if you have a good selection, but also maintains all of the benefits of the ACURATE neo platform. Thank you very much for your attention.
Thank you for nice lecture. Discussion will be held at the end of the all lectures. The second speaker is Andreas Rück from the Karolinska University Hospital, Sweden. The lecture title is Commissural Alignment with ACURATE neo2. I wish a good lecture, please.
Thank you very much for the introduction, and thank you for inviting me as a speaker. As you know, commercial alignment is a quite popular topic, and it's discussed with many products on the TAVI market, and I will show you specifically how it works with the ACURATE neo2 platform. So first, the idea behind commercial alignment is to not have stent posts of the prosthesis just in front of any coronary. And as you see in these two pictures, in the A picture, you have a good commissural alignment, and there you have one stent post of the prosthesis midway between the two coronaries, meaning that both of the coronaries are far away from any stent post. And then if you look in the B picture, you have a rotation which is 60 degrees different, and then you have one stent post in front of each coronary. Now with this platform, you can implant with complete misalignment, and you will still have good coronary re-access usually, and you will not have a coronary occlusion anyways in the acute result. The idea with the commissural alignment is more the long-term treatment of the patient. And that's, I think, also other companies use the word lifetime management. And that really means that we should plan that the patient should be able to receive one more TAVI valve in their lifetime. And that's, we think, with this platform, it's well possible if you do the commissural alignment. You will probably have a little bit better coronary access also with commissural alignment, but as I said, even if you implant this valve at a random rotation, it has been shown that the coronary access is very good for a PCI after procedure anyways. But most importantly, if the valve fails after the implantation, it should be possible to implant one more TAVI, and then it's more important to be able to do a basilica procedure with leaflet modification, and of course the effect of a basilica will not be good if you have a stent post just in front of the coronary. There are some potential benefits that have not really been shown but could be true, like reducing PVL, improving sinus washout, reducing leaflet thrombosis, but that's more speculative at the moment. So first, we need to understand the imaging planes that we use and what they show. So as I said, the commissural alignment idea is to have one stent post where you have the two coronaries, and the view where you have the two coronaries superimposed is the so-called cusp overlap view, which is commonly a REO view. And there you will have the left coronary and the right coronary superimposed on the inner curve, as shown on the right-hand picture with the light blue and the red dot. However, if you go to the standard three-cusp view, which is commonly used for implantation of the valve, you will have the left coronary and the right coronary on different sides. So that means that to have a good coronary commissural alignment in the cusp overlap view, in the REO view, where you have both the coronaries on the same spot in image, then you would like to have one stent post pointing towards the coronaries, and then that stent post should be between the coronaries. We'll go into detail on this later. This valve system, I think, has some unique features that helps us with a commissural alignment. So to do a good commissural alignment, you need ideally multiple markers on the stent, which are clearly visible on fluoroscopy. This valve is unique in the way that you see the stent posts well. There are 3 of them, and all 3 are visible. And there is also one small unique feature, which is called the wing or free cell, which is more towards the inflow part of the stent. And you see it in the left picture, the so-called free stent strut pointing out. And that's visible before the deployment of the valve. So you actually have then on 2 different levels, you have 3 markers. So in total, you have 6 markers on this system, compared, for example, to the Medtronic system where you only have 1 marker. And I think it's fair to say on the Edwards you have 0 markers for this at the moment. So the more markers you have, the more precise you can be with your commissural alignment in your procedure. So with this valve system, how would it look on fluoroscopy with a good alignment and a misalignment? I marked in green in the upper left part here, where it says in the middle 0, that's 0 degrees misalignment, which means a perfect alignment. Then you see in the 3-cusp view, you have the 3 stent posts nicely lined up with equal distance between them. The left-hand picture marked in green. And in the cusp overlap view with the valve in the same position, you see that you have 1 stent point pointing to the inner curve of the aorta and the 2 stent posts actually overlapping on the left side. So that's the ideal position. If we then go to the right side of the picture marked in red, with the 60 degrees misalignment, which is then the worst position of the valve, you will see that in the 3-cusp view, that looks exactly the same actually with them lined up. The difference being that the middle one being in one case in the front and in the other case in the back, but you will not be able to see the difference. So to spot the difference, you need also to use the cusp overlap view, the REO view, which will look inverted if you look in the right picture, which is marked in red compared to the one with 0 misalignment. So that means you need to use at some phase a combination of the 3-cusp view and the cusp overlap to make sure that you don't make a mistake. We developed a technique together with a company and also with other centers. It has already been proposed that the insertion of the valve should be with the flush port down at 6 o'clock. With other systems, they have other proposals of the initial position. You will see in the end how much this helps. And then we advance the system almost to the desired position, but we do the alignment approximately 1 centimeter higher than the desired implant position. And then we first check in the cusp overlap view if we have the perfect or the misaligned configuration. That means if we have the free cell pointing to the right of the picture or not. Then we go to the 3-cusp view, which is commonly also then kept for the implantation of the valve. And then we try to achieve the 1, 1, 1, which means the equal distance between the posts. And then that also means these wings, which are marked with blue dots in images, should be 1 equal size on either side of the system. And there's also rules how to rotate. So if you start with a 2-1 configuration, you should go clockwise. If you start with a 1-2 configuration, you should go counterclockwise to have the shortest possible distance on rotation to achieve the perfect position in rotation. You can forget that rule and you will still get to the perfect position, but you will need to rotate more in that way. And if after the alignment has been done, you should relax the handle and allow any torque to dissipate, and then you just go on and implant with the regular way. We have a example, a recorded case here. That's a 2-minute recording. I hope you hear the sound of the recording, do you?
It's difficult to hear, Andreas.
저기는 귀까지 다 막네. 귀까지 다 막어. 옷을. 완전히 중무장하네.
Okay, that also shows, I think, the common steps during the deployment of the valve, which Dr. Kim already alluded to. And as said, it's a quite good system in a way that it's, I think, a quite precise placement where you achieve an implantation depth that has a quite low variation from patient to patient. And I think it was already said, but with this system, we don't aim for a zero position, very high implantation. That's not necessary to avoid pacemakers. And the ideal position is something like this with 5 to 7 millimeters implantation depth. That's probably the ideal position with this valve system. If you want to try out the commercial alignment without doing it in a patient, when you start your cases, there is actually now from Boston Scientific an online demonstrator of this where you can do all the maneuvers and deploy the valve on this web page, and you will get feedback how well you did the alignment. We have at EuroPCR this year presented results of commercial alignment. It's single center only from our center. And since we started the commercial alignment with this system and set up as I showed you, we have had 170 patients, and in 167 we were able to analyze them. In the other 3 there were not sufficient images saved to analyze the final result on rotation. And the result in short is that 97% of the patient had no significant misalignment, with 80% being no misalignment, 17% mild, 1.2% moderate, and only 1.8% severe misalignment. And the average time it took to do these steps with the rotation of the device was 92 seconds. And I think now, 1 year later, it's probably even quicker to do this. So this shows that you can do it in almost all patients and have a very good success rate too. We try to understand also if only by doing the 6 o'clock insertion, if that's good enough. So we check the initial position of the valve in rotation when you come around the arch and when you are just before starting the implantation. That's step 1. And depending on the definition, between 20 to 46% of the valves are misaligned if you just do the 6 o'clock with the flush port. So it's clearly better than that when you do the rotation. And then when we went down and went over to the 3-cusp view, we could also check the rotation before these maneuvers were done. And we can say that only 25% of the cases are optimally aligned without any rotation. And the most common rotation to do is counterclockwise, actually. So this shows, I think, that there is a clear benefit of doing this rotational maneuver, which takes only about a minute to perform. So in short, commercial alignment with ACURATE neo2. I think it's fair to say that this is a quite ideal system to do it with, since you have multiple radiopaque markers and also a torqueable delivery system. You should use a combination of the 3-cusp and the right-left cusp overlap views during the implantation to avoid mistakes. There are some simple rules to follow for the rotation. It's possible to do this also in tortuous anatomy in our hands, so we could do it in almost all patients. You have a high success rate, 97%, and it seems to be fast, 92 seconds on average in our first 170 cases. Thank you.
Thank you for a nice lecture, Dr. Andrea. Next title is Real-World Experience Sharing with ACURATE neo2. The lecturer, Won Kim. Please start it.
Thank you very much again for the introduction. I have to switch back. So Yeah, now I have the pleasure to talk about the real-world experience with the ACURATE neo2, and I have interpreted it as more giving you some tips and tricks because in terms of data, in the first presentation, I think I've shown you that there's good outcomes with the ACURATE neo2 in terms of PVL reduction, and Andreas has already talked about commercial alignment. I might show you one or two slides that really help to understand why we should do it, and also a very nice example that shows how it looks in valve-in-valve case. So maybe from the first presentation you recall, I've been talking about limitations. Talking about limitations is not nice, and I hope you recall that severe eccentric calcification is not good for the ACURATE neo. Sizing, we can only treat up to 26.578, and appropriate sizing has been shown to be extremely important in order to achieve good outcomes. And I can try to explain, for instance, scope 1 and 2, what were the problems of scope 1 and 2 with extremely high rates of moderate to severe PVL, 10%, which was not consistent to our real-world experience in more or less experienced centers. And I think in scope 1 and 2 the problem was that a lot of less experienced centers were part of the trial, and I think you need experience in order to have optimal sizing. And as I showed you, sizing is really critical to achieve good outcomes, and usually we need to have a little bit more oversizing. So for example, if you have an annulus, so this is the official sizing recommendation, and if you have an annulus of, let's look at the perimeter-derived annulus, 22.5 or 6, the official sizing recommendation would be to implant a small size, or a 23 millimeter ACURATE neo or ACURATE neo2. And early in our experience we found in order to reduce the risk of PVL, it's better to choose an M instead of an S. And it's the same for these borderline sizes, 24.7 millimeters. If you have no experience with the ACURATE neo, you would probably choose an M, and clinical experience has shown that probably in these cases upsizing to L leads to better outcomes. This is one of the key issues I think that contributed in scope 1 and 2. And I'm also part of the screening committee for the IADE trial, and I can tell you that around 10 to 15% of sizes that are suggested by the sites differ from what we as screening committee finally recommend. And you have to be aware of the fact that in scope 1 and 2 there was no CT core lab, so there might have been also measuring errors and no screening committee for final size recommendation. And this is also to recall that upsizing, more oversizing led to better outcomes. So proper sizing is key, and I would like to highlight 3 mechanisms that we should keep in mind. One is common annulus measurements. So if there are some measurement errors, so this is very basic. Another very important thing is, and this is really clinically relevant, Lanke 10 years ago already showed that there are cyclic changes of the annulus. You can see that the annulus is largest if you measure in systole, but also systole, in systole there are differences. There is a difference between 40% of the cardiac cycle and 20%. So there can be really differences, and especially if you measure in diastole, the difference can be really relevant, and you see here clinical examples that illustrate that the measurement between systole and diastole can lead to different size selection. Here we have 22.9 perimeter derived, which would lead to size M, and only looking at the measurement in diastole, you would choose the size S. So the problem is, if you have a center that only uses diastole, then you can assume that the risk of undersizing is increased. But a little bit of problem is also if you only have systolic reconstructions, because systole is not always larger. In around 10%, diastolic reconstructions can have the same size or can be even larger than in systole. So usually, in order to have the highest amount of safety or security, it's best to have systolic and diastolic reconstructions, and usually we choose the largest size annulus dimension for sizing. This is a very recent analysis that we did, a sub-analysis of the two-center registry with 2,800 patients. You recall it, 2,000 neo patients, 800 neo2 patients, and this is a little bit busy, but I think it's worth it. It's just under review in JAC intervention, and here you see on the left-hand side, please only focus on this left-hand side panel. Here you see the sizing considerations of the neo, so the first generation. You see the color. These are each dot represents one patient that we treated, and the color represents the risk of PVL. Red color means high risk of PVL, and blue color means low risk of PVL. On the here we have distinguished between no eccentric calcification and eccentric calcification. On the y-axis here is also the cover index. So here we have a higher cover index. 10 would mean more oversizing, and 0 less oversizing. So you can see, and also we have discriminated for each size. And for each size, S, M, L, for the neo, you can see if there's no eccentric calcification, the risk of PVL remains low overall, but is increased when you have less oversizing, especially in the borderline sizes. If you have eccentric calcification using the neo, the risk of PVL is always increased, and this is independent of sizing. So now look at the neo2 data. If you have no eccentric calcification, then the risk of PVL is very low, and even though you employ less oversizing, here are the borderline sizes, it is quite safe to in terms of PVL. So the message is, if you have no eccentric calcification, the risk of PVL is low, even though you don't have too much oversizing. It's a little bit different for eccentric calcification. You can reduce the risk of PVL in eccentric calcification if you employ more oversizing, but of course in these borderline sizes, if you do not have enough oversizing, then you will increase the risk of PVL. So this nicely shows the difference of sizing between neo and neo2, and this is very new. I hope we will be able to publish it soon, and this is the sizing algorithm, the suggestion for the neo2, and with some modification that you can take into account depending on some additional factors that are shown here. So in terms of positioning, if you recall the sapien positioning, there has been a major change. This was the initial recommendation of how to position the sapien 3, and now the common positioning is very high. It is here. But for the ACURATE neo, I would say that you cannot translate this to the ACURATE neo. So positioning like this would be too high. And I would try to explain to you why this is the case. The positioning not only relies on the marker band that is new with the ACURATE neo2, but also on the relation between the upper crown and the native leaflets. So the distance between the upper crown and the native leaflets should not be too remote. We always should try to have the upper crown adjacent to the leaflets, otherwise there's the risk of pop out. And here's a very nice example actually that we had recently. You can see that due to the calcification, and here you can see that the upper crown is sitting very tightly on the calcified leaflet, and due to the upper crown it is not possible to go even deeper. So if you would only look at the position of the marker band, you can see it is not possible to bring the marker band down to the annular plane. Yeah, we are forced to do the deployment, and here it looks okay. And in this case, what I recommend is to either use fast pacing or even rapid pacing in order to enhance stability for the deployment. You need also to have enough forward pressure in order to prevent an upwards movement, because basically this position actually is too high. But sometimes there are anatomic limitations of positioning the marker band really in the annular plane, which usually should be the case. We have analyzed this and also identified some risk factors: oversizing, parallax, not sufficient forward pressure, and also the position and the risk of valve dislodgement would increase if one of the factors is present. Maybe one word to commercial alignment, and this is an example on the left-hand side. I don't know whether you can see it. In the initial presentation I showed you an ACURATE TA, and this is an ACURATE TA valve. So it was implanted transapically a few years ago, and actually Thomas Walter, if you recall, 10-12 years ago already was talking about commercial alignment. At that time nobody was interested, and from the transapical axis actually it's very easy to achieve commercial alignment. In this case it was not employed, and this patient came back with inferior STEMI. You can see that the right coronary artery is occluded, and I was able to perform diagnostic coronary angiography, but I was not able to perform PCI because there was no sufficient backup, even with multiple wires, microcatheter and guide extension. It was not possible, and the patient died a few days later, was too old for CABG. And this very impressively shows why commercial alignment should be employed. Andreas has nicely demonstrated that it is possible in the vast majority of patients. And the main goal is not to achieve perfect commercial alignment, but to avoid commercial misalignment, as you can see here. This has been also nicely summarized in this review recently published in JACC Intervention. Here's a very nice case of valve-in-valve that shows how the alignment actually works. This is a degenerated trifecta. This is off-label, not approved by Boston, and here you can see the final aortogram, and you can see how nicely the commercial tabs are aligned with the stent posts of the prosthetic valve. This is maybe one topic that might be of less interest to those who haven't used the ACURATE Neo. The recrossing is a little bit complicated. As you can see, there are 3 stabilization arches, and if you have the necessity to recross this valve, it is very important to do it carefully and to be central and not through one of the arches. And here you can see what could happen if you recross the valve incorrectly. This was after balloon postulatation, and you can see we were outside, we went through into the valve outside of one of the arches, and so we, this increases of course the risk of valve embolization. I hope you can see it, and it is very important to employ a specific technique if possible. It's recommended to use pigtail only. Sometimes it will be necessary to use a wire in addition, but it's important to place the pigtail centrally. And afterwards, it's very important to check whether the recrossing was okay or not. And here you can see how it looks like when there was incorrect recrossing. Here you can see that we are outside of this stabilization arch. And if we have incorrect recrossing on the outer curvature, then you can see that the wire will not travel to the right hand side, and this should be checked in the cast overlap view where the two posts on the left hand side overlap and one post on the right hand side is isolated, and you can see that the wire doesn't travel freely to the other side. This is the other way around if there is incorrect recrossing to the inner curvature, and you can see that the wire is stuck here and will not travel freely to the other side. And this is how to do it. You can see a wire that crossed correctly. There's movement from the left to the right side. And here again, a very nice example. This was incorrect recrossing. You can see that the wire is stuck here, and after correct recrossing, you can see there's free movement. This is nicely summarized here in this wrap-up. So maybe a final word in regard to valve embolization. Valve embolization is one complication that can happen, unfortunately, and there are several bailout options. Of course, conversion to open heart surgery is rarely necessary. I would like to show you quickly three options that you can do valve and valve. The most frequent option is Sapien 3 or Sapien 3 Ultra, and we have done it a lot of times due to malpositioning or PVL. This has already shown that the implantation of a second valve in the ACURATE platform is quite safe. Here's one case that we did. You can see that there was an upwards movement, dislodgement as shown here, and this was treated with a second valve. Here's the outcome. So you can see, due to the geometry of the valve, there is no impairment of the coronary arteries, even after valve and valve. Here's another case that was a little bit more complex, and for some reason the valve popped out. We did postulatation and lost position in the annulus, and the valve finally went into the ascending aorta. In this scenario, what you can do, if the valve is stable in the ascending aorta, just leave it, do nothing. Don't try to snare it in the descending aorta, because there will be injury of the aorta due to the upper crown. And if there's considerable movement, as you can see here, then what you can do is to use a pigtail catheter or anything else that pushes down the dislodged valve, and then you can anchor the dislodged valve in the upper part, as you can see here. You can anchor it. So I would do this only if you have really a lot of movement of the valve. And you see here, of course, admittedly coronary access would be difficult, but no coronary impairment. This is the last example. This was less experienced colleague during withdrawal of the delivery system, the valve popped out, was too high, and due to PVL, we decided to just put a stent. We've done it in a series of patients. So this is a bare metal stent that we have in stock, and the theory behind it is that we would not cover the leaflets. We have the functional leaflets and have anchored the valve, and there's no PVL. So I would like to summarize. It is very important to have careful sizing, correct positioning are key for procedural success, and this is very important. The ACURATE Neo is a little bit less forgiving in terms of sizing and positioning. Commercial alignment can be easily achieved and should be pursued. I've shown you a very impressive example of why we should do it. And in the event of recrossing, the correct position should be verified. This is very easy with the method I've shown you. And valve dislodgement, unfortunately, still occurs, but with a distinguished approach, I think we also can address this severe complication. Thank you again for your attention.
Thank you for a nice lecture, Dr. Won-Keun Kim and Andrea Lucas. We had 3 lectures by 2 excellent interventional cardiologists. As you know that in Korea we have no experience with ACURATE Neo, but device now is available. So we will start it, the procedure with ACURATE Neo within a week. We have 2 excellent interventional cardiologists as panelists, Dr. Sang-Nok Lee and Won-Jang Kim. Any comment or question for 3 lectures? Won-Jang Kim?
Thank you for your comprehensive, nice lecture, Dr. Kim. I'm also Dr. Kim, as you recommend. I
Nice
remember
seeing you.
that. Yeah.
Good to see you again.
Good to see you again in the internet. So, as you well known about the Korean situation, we already 12 years introduction is well known about the Edward Safin and Cobell. So we don't have any what about you just some point out that what we do introduction of a new system with ACURATE Neo in the Korean situation. We don't have too much some more than the balloon expandable and self-expandable. Or what about some position of the ACURATE Neo in between the 2? Usually, I personally balloon expandable is well some prediction of the oversizing and undersizing and well documentation of the positioning, and the other one is self-expandable. It have a unique positioning of the hemodynamic unstable and bicuspid area, and sometimes in a low coronary height. We have a lot of experience and have a correct positioning of the self and some balloon expandable. Or what about some correct positioning of the ACURATE Neo in the Korean situation? Yeah.
Andreas, would you like to comment on that? Or?
Yes, so if you look at the European situation, I think Dr. Kim and myself represent centers where the ACURATE Neo is used in a very broad population. I think in my center we use it in almost 70% of the patients, but that's quite unique. And if you start with a new experience, I think there are some patients which have unique benefits from the system that are, it's for example, patients which have tortuous anatomy, where the iliacs or the aorta has bends where other systems would struggle to come to or cross that. So I think these patients, and then if you avoid patients which have excessive calcification, then you will have good patients to start with. Of course, as you learned the Neo or neo2, is approved officially up to 27 millimeters, and in practice is usually used up to 26.5 millimeters of perimeter-derived diameter. So the largest patients would be screened out, of course.
Yeah, maybe I can add. I've shown you in the first presentation, there are a lot of beneficial features of the ACURATE neo. And I think it has a comparable hemodynamic profile. So gradients are very low, which I think is important for long-term duration, but at the same time has a very low risk of coronary obstruction. And I think this might be very important in the Asian population. I've been in Bangkok last week, and in Bangkok, and this might not be that different in Korea or Japan. The patients are much smaller than in Europe, and coronary distances are very small. So I think the ACURATE neo might have some position, especially in the Asian population. And I think another very good feature of the ACURATE neo platform is the low pacemaker rate. And currently in our center, real world, without trying to implant too high, is 7%. And it's still the lowest. I'm also using Evolute, Portico, Navitor, and also Sapien with a very high implantation position. And sometimes we aim at 0, and still all other platforms are higher than the ACURATE neo. So I think this is also one example that you might take benefit of. And yeah, I think it is also very nicely usable in very horizontal aortas and tortuous anatomies. So you might have to figure out which position the third device will take. But especially in terms of long-term management, and if the numbers of patients increase also in Korea, and if you try to treat patients that are younger with lower risk and higher life expectancy, I think the aspect of coronary reaccess will also become very relevant. And I've shown you one example, but we have data that using the core valve, the Medtronic platform, the risk of no reaccess is actually very high. Yeah? And we know it from all the data that we have seen. And coronary access is possible in most cases, but this is for diagnostic coronary angiography. You have seen in the example I've shown you, there's a difference between diagnostic coronary angiography and PCI. The requirements for backup are much different. And if you look at the numbers only for diagnostic coronary angiography, it is 90%, 95%, which is good. But if you think of coronary access in native anatomies, it's 100%. So I think we really have to think about coronary access, and this is becoming more and more important when we try to take into account lifetime management. So patients coming back with a valve. This will be increasingly the case also in Korea.
I have a simple question to Dr. Kim. In your valve embolization case, you put another type of valve. So in this situation, we have to prepare another type of valve?
Exactly, yeah.
Really?
So we have the most experience with Sapien. I think in 90% we use Sapien, but you can also use Medtronic, Evolute. We have also experience with a second ACURATE. So actually we have experience with all combinations, but of course, and it depends on the mechanism, whether it's pop out or whether there's still some contact with the annulus, or whether it embolizes into the left ventricle. It depends a little bit on the mechanism, but usually with any one of the commercially available valves, you can address this complication.
Okay, I think that the most distinguished different point compared with other the pre-existing valve, the Evolut valve and then the Sapien valve, the ACURATE Neo has a upper crown and top-down valve deployment method, right? When it comes to upper crown, I have a concern about the possible traumatic injury of upper crown to SOB. And second is obstacle to correct positioning by upper crown. Is it possible? What do you think about that?
Well, if we look at the published data, it's possible to have an injury of the STJ or the sinus of Valsalva from the upper crown. But if you look at the data, it seems to be very rare.
Very rare.
I think in the registry, which I was initiator of, I think we might have had one case in 500 patients. So it seems to be very uncommon. And I think probably would only occur in the cases where you're not positioning the valve correctly. That means if you position the valve really high, then you have the upper crown pointing then towards the STJ height. But if you implant it at 5 to 7 millimeters, as said, then the upper crown will be approximately 12 millimeters into the sinus of Valsalva, which means there will be ample distance to the side of the sinus of Valsalva.
Okay.
I would agree. So the injury of the upper crown is extremely rare. It's not that it never happens. I had one case after post-ballooning where the upper crown caused aortic dissection. That's true. But this is after we've done around 2,000 cases in our center. And this is one of 2,000 in a very small anatomy. And I think no valve is perfect, and if there are so many different difficult anatomies out there, so I think you can classify as extremely rare. But of course, have to keep in mind that this could happen.
Okay. Any question? That's it. Yeah. Okay. Thank you for very excellent lecture and comment. And we have a very informative and educational talk by you. So thank you very much. We have no time, so this close this session. Thank you.
Thank you.
Thank you.
Good luck with the
Thank you very
upcoming
much.
cases.
Bye-bye.